I would like to introduce the other panelist, Dr. Hürmann, President of the ENT Society, German ENT Society, Head of the ENT Department in Mannheim, Dr. Lehmanns from Amsterdam, and Dr. Olsen from Rochester, United States. Dr. Knecht asked me to discuss only one special topic because, as you heard before, surgery in multimodal treatment is a wide field. And in the 25 minutes left, it's not possible to discuss all these aspects Dr. Shah mentioned before. And therefore, I would like, next slide please, I would like to discuss the role of surgery after primary concurrent chemoradiotherapy. I think at the moment it's a very important topic. We try to treat our patients with chemoradiotherapy simultaneously, and after the treatment we have to look at the patient and we have to decide if it's necessary to do surgical procedures or not. Next slide, please. And therefore, first, we have to decide when should we perform restaging and which investigations we should do. And these are the first question. It is the first question to the panelists. The restaging after primary, concurrent or simultaneous chemoradiotherapy. And we should go across, starting with Dr. Hürmann. What would the diagnostic procedure and when would you do it after concurrent chemoradiotherapy to look if the patient has a complete response to the treatment?
We see the patients in the first year every month, and we do imaging like a CT scan to document the situation and ultrasound.
Yeah, this is a very pertinent question, of course, and it continues to evolve, and every year we learn more, also as more techniques become available. What we do in primary operable cases that were treated with organ preservation protocols, chemoradiation, we do imaging, of course, we do MRI scan, we do a PET scan, and we do an examination in a general with blind biopsies, but not too soon after the treatment. So at least 2.5 months, preferably 3 months after treatment.
3 months after treatment?
Yeah.
The first investigation?
Yes.
Okay, Dr. Olsen.
I would typically see the patient a month after completion of the chemotherapy and radiation therapy and just perform an examination and assessment at that time. I would want to get as much information as I could initially about the extent of the original tumor and where it was located, because that's going to impact my concerns about possible recurrence and where I'm going to want to evaluate that patient in terms of what type of imaging modality I'm going to do. There's also the very practical realities of certain types of patients will have certain types of insurance programs that will allow them to only have certain coverage for certain imaging studies. But in general, if, for instance, if it's a laryngeal cancer, I would just examine them at a month, and then at 3 months see them and establish some type of a baseline scan. Usually for, let's say, larynx, I would get an MR scan or a PET scan. If it's something in the oral pharynx where I'm concerned about parapharyngeal, retropharyngeal areas that are difficult to assess on a clinical examination, again, either MR or PET. I prefer PET because it also helps me to look for distant disease at the same time. And then I would embark upon seeing the patient every 3 months in conjunction with our radiation and medical oncologist. And we typically would do imaging studies at about a twice-a-year level for the first 2 years.
Yeah. Dr. Shaw?
There are a rare number of patients who will manifest progression of disease during chemoradiotherapy. Minority. Those patients should be imaged early and intervened early. Having taken those out, then there you have 2 sets of patients. Those who have manifested expected response, near complete disappearance of the primary tumor, extensive mucositis, and significant response in the neck. those patients you should not be in a hurry to image or restage. I would agree with Renee, 8 to 10 weeks at a minimum, as long as you've seen at least a PR, partial response, both at the primary site and the neck at the completion of treatment. The one caveat is if you have less than a PR at the primary site at the conclusion of treatment, that patient is not likely to do well and may need salvage surgery. That patient you are going to be much more vigilant in screening. Vigilant doesn't mean earlier scanning. That means you don't let that patient fall through the cracks. If he doesn't show up for appointment, call him and get him back, because that patient is likely to fail. But generally, restaging at least 8 to 10 weeks after completion of treatment.
At least. And the latest? If you consider to perform surgical procedures on the primary side or on the neck, and we know after chemoradiotherapy, we have a distinct time between the end of the radiotherapy and the best time to start surgery. That in Germany, in my department, about 3 or 4 months, not later normally. And in your opinion?
If you are going to dissect the neck, you must have a reason why you are dissecting the neck. So time frame is impractical. If you are operating upon the neck because you suspect persistent disease, you do it as soon as you are able to document that. That means once you do the imaging shows residual disease, the PET is positive, or you are able to still palpate residual disease in the neck, intervene soon. There is no reason to wait after that.
Okay. Any question from the audience? Do you perform general anesthesia in the patient to have histology from the tumor region after the end of the chemoradiotherapy routinely? Do you perform microlingual endoscopy to look at the tumor region, the primary site, and to have histology? Dr. Neumann?
Yes.
You do? Dr. Clemens?
Routinely. Almost always, but not if it were, for instance, a T3 larynx carcinoma which regained mobility, and it's quite well possible to see it in the outpatient's office, and there's absolutely no tumor visible. I would probably not do an EUA or a laryngoscopy on such a patient, but all the others probably will get a standard EUA.
Dr. Olsen?
In the absence of clinical examination that has a suspicious lesion or something that shows up in imaging studies, I would not routinely take a patient to surgery and biopsy them. No, I would not do that.
We would do it very selectively. If we suspect something, if the clinical examination is inadequate or clinical examination is negative but PET is positive, we will bring the patient to endoscopy, but selectively.
Okay. Pat.
Hi, I'm
Following
Alex.
on with that scenario, if you had a positive PET and you got a negative histology, when would you then intervene, or would you continue to strive to get a positive histology to salvage your patient?
We are on a learning curve with PET, and there are many reasons besides the tumor which may give a PET positivity. If the larynx looks pristine on clinical exam, and at endoscopy you see nothing, but the PET is positive with a low SUV, I would simply follow the patient, get a repeat PET in another 6 weeks or so. I don't think there is virtue in going to do deeper submucosal biopsies where there is nothing on anatomic imaging, nothing suspicious on clinical exam, and just because the PET is positive. Conversely, if the PET has a high SUV, 7, 8, 9, there is a slight doubt that there may be abnormality below the mucosa, we would do a CT-guided needle biopsy rather than open biopsy submucosally.
Okay. There was another question from the audience?
Hello, I'm Alex Rapidis from Athens. Would you use tattooing the primary tumor before you send them to chemoradiation? And if you're going to do surgery afterwards? Would you go to your initial marks, or you will just do the resection on the clinical or on the histopathologically proven area of the head and neck?
I think we come later to this point. It's a very important question, but in the discussion we come to this point later on, please. Okay? Good. Next slide, please. Okay, now we assume that the restaging shows no tumor anymore at the primary site, and before the treatment, before starting the treatment, you had a N2B or N3 neck. And now we have to ask if it's necessary to perform, next slide please, a neck dissection or not, or in which cases, nächstes hier bitte, or in which cases we should perform neck dissection after primary concurrent chemoradiotherapy. Dr. Shaw told a little bit about, but now what's your opinion in neck dissection after primary chemoradiotherapy if the primary side of the tumor is cured?
I think we as surgeons should not be pulling N2B and N3 together. Surgeons understand that better than non-surgeons. They are different diseases. 2 1 centimeter lymph nodes at level 1 is N2B, and an 8 centimeter lymph node in the posterior triangle is N3. So we can't combine them together. So N2B, if there is complete response on clinical exam, anatomic imaging, and a negative PET scan, we would follow the patient. No surgery.
No surgery.
And 3 disease, my threshold will be much lower in terms of embarking upon neck dissection, because the probability of isolated foci of metastatic cancer in the soft tissue, not in the node, is much higher. So if you start off with N3 neck disease, my threshold for doing a neck dissection would be higher in spite of the negative scanning studies.
Okay. Dr. Olsen.
I would go by the bulk of disease in the neck. And anytime I would feel palpable disease, or have any imaging studies that are suspicious for recurrent tumor in the neck, I would always do a neck dissection. For large bulky disease, prior to that, clearly all of the N3 disease, I would do a planned neck dissection as part of our initial treatment.
As we also tried planned neck dissection in the past because nobody knew what to do, and we have come across many cases that even the cytologist told us that there were viable tumor cells in, and then histology showed no viable tumor cells, and then the wound breakdown, etc. So I would be very reluctant in doing planned neck dissection in view of negative imaging studies, negative PET. Also, the response at the primary site does tell us something about the response in the neck, of course, and here we have a situation in which the primary has regressed completely. So I would not do any more planned neck dissections, but only go by the examinations as just mentioned.
We had this week, in one night, 2 extreme bleeding cases after combined radiochemotherapy and neck dissection. And so I think we have always to keep in mind that we have not surgery in healthy tissue. We have surgery in tumor-bearing tissue which has had a chemo radiation, and we should not do an assisted death. We should always keep in mind the overall survival of our patients is limited, and we should help them in their time and not shorten their survival. And I think if we do a neck dissection in a case like you mentioned before, we don't help the patient.
Any comments from the audience?
Yes, I'd like to make a couple comments. On the one hand, while the N3 neck might be a place where you would do a planned neck dissection, another indication that we find for a planned neck dissection, often even when there's a complete response in the neck, is for low-lying lymph nodes, such as level 3 or level 4. And not only for local regional control, but for purposes of staging information. And this relates to the comment that Dr. Lehman's just made, where the primary site can give you an indicator of what's going on in the neck. What's going on in the neck can give you an indication of what happens at the primary site. And in November, in the archives of European Archives of Otolaryngology, we published a series of oropharynx cancer patients in whom we dissected their neck after radiation therapy, not N0 necks, but where there was some even small residual disease. And 2/3 of those patients had N-positive disease, and of those, they had a high rate of treatment failure, not just in the neck, but at the primary site too. So it may be a staging information about radiosensitivity of that tumor. And while I'm up here, I'll just chime in about another major center, MD Anderson, and how we tend to follow people after surgery, or after chemoradiation. At 6 weeks, most of our protocols will perform imaging, usually with a CT scan, and then do surgery at that time, and it will be only for usually for residual disease or, again, N3 or low-lying neck disease. And in terms of follow-up, we tend to follow these patients at 3 months, and we don't do routine EUA in the operating room. We go by our clinical exam, similar to what Dr. Olson said, and if there was indication of positive residual disease on imaging or physical examination, then we might take that patient to the OR for evaluation and biopsy. Again, similar to what Dr. Herman just said, trying to avoid biopsying post-radiated tissue that might not have tumor and then increasing the risk of radionecrosis.
Any comments? No. Okay, thank you. Next slide, please. We know that the high dosage of radiotherapy will have very often complications after surgery. And the question to the audience, does the concurrent chemoradiotherapy, and I mean the radiation dose, influences the concept of neck dissection? That means if you decide to perform neck dissection in the patient, which kind of neck dissection do you perform? To perform a modified radical neck dissection, a radical neck dissection, or to perform only, let me say, node picking? You find a node, you see the node in the ultrasound, the CT scan, and you look only at the node, you remove the node, or do you perform the neck dissection completely? Dr. Shah.
I think to alter the type of neck dissection based on radiation dosage would be improper. You are doing the operation for excision of potential residual disease, not because of the radiation dosage. If you are worried about wound complications, excise the skin and put in a flap, but don't compromise the operation because of the radiation dosage.
Okay.
The issue about comprehensive versus selective neck dissection needs to be very, very urgently addressed, because we do know that nearly 40% of the patients who undergo planned neck dissection will have negative specimen.
Yeah.
What we need to know that of the remaining 60% who do have demonstrable residual disease, where is that disease located? Is that disease located at the site where the initial large volume disease was present, or is it at all 5 levels? We are currently doing that study, albeit retrospectively, to look at the surgical specimen of those patients who underwent salvage neck dissection and planned neck dissection to see the distribution of viable tumor in the excised lymph nodes. We will be presenting that information at the August meeting of the American Head and Neck Society in Chicago. I don't know the results yet because it's still study in progress. But information such as that would allow us enough material to develop or to embark upon a trial to compare comprehensive planned neck dissection versus nidectomy or a selective dissection. Until that time, I think if you're going to do the neck dissection, you should do a comprehensive neck, because we do not have data to support limiting the neck.
Okay. Dr. Olson.
I very much want to know what the status of the neck was before I operated on the patient and what I see at the time that I go into to perform that neck dissection. And I have a lot of flexibility in terms of my approach to those patients. Meaning a lot of times in a post-chemo radiation neck, the neck is very swollen, hard, difficult to examine. And if I'm looking at someone who's had an N3 disease and they still have palpable disease, I can tell you initially my approach is going to be to do a comprehensive neck dissection. If it's a situation that I'm doing it because of concern, N3 disease before, small palpable disease, I don't have any problems with going in and doing a comprehensive modified neck dissection and saving any structures that do not appear to be involved. But very often you get in at the time of surgery and you can't separate out what is scar and what's residual fibrosis at the time of the operation. And any time I see those findings, I'll take out those structures at the same time, just because of the unknowns that Dr. Shah just said. You can't tell what is going to be tumor, what's going to be fibrosis in those situations. So it's an ongoing assessment that I make at the time of the operation for many of those cases.
Dr. Lehmanns?
Yes, we have a similar approach. It's dictated by the original tumor and what still might be present in the neck based on your examination and imaging studies. I would usually or typically do also a comprehensive neck dissection. We have not gone to selective neck dissections in these cases, and I would also have a very liberal approach as to bringing in vascularized tissue just to prevent wound breakdown and things like that. So a myofascial pectoralis flap or something would be typically brought in then.
Yeah, but I think we should always keep in mind that we deal with a disease which is not limited and not cured after 3 months and so on. I think the wonderful case you presented as extreme surgery, where you replaced nearly all the skin from mastoid to mastoid with a flap, demonstrates on one side the chances we have with flaps, but on the other side also the death of this patient because his carotid artery ruptured, demonstrates there is a limit. The limit is maybe in 18 months. And so if we decide to make a bigger approach to the neck, we should keep in mind there are vessels who can rupture. And as I understood, this case had no evidence for recurrence of disease, but he died from rupture of his carotid artery.
Let me refresh your memory. That surgery was strictly for palliation of a fungating, bleeding, foul-smelling tumor, so he is socially presentable. The potential for cure in that patient was 0.
Yeah, I agree.
The aim was palliation, and I think it was effectively palliated.
Please, next slide. One more, please. Next slide. And next. In my experience, in my department, the chemoradiotherapy is used with 73 to 75 Gray on the neck. And in my experience, we have a lot of complications after this kind of treatment performing neck dissection. And very, very often, flaps are necessary to reconstruct the neck area. How often, in your opinion, Dr. Shah, it is necessary to use flaps performing a neck dissection after chemoradiotherapy?
If it is strictly a neck dissection and not associated with laryngectomy or pharyngectomy, the need for a flap is usually infrequent unless the tumor is stuck or adherent to the skin and when you have to sacrifice the skin. If that is the case, you would simply rotate a pectoralis or a deltopectoral flap. I don't think you need a free tissue transfer just to cover the neck. But if you have a microvascular surgeon available easily, and if you want to put in a radial forearm or a rectus flap, it's perfectly fine. Any vascularized tissue is necessary if the skin needs to be sacrificed or is a matter of concern at the time you start closing the wound. If the skin looks blue, it's turgid, the edges are oozing out blue blood, you better bring a fresh tissue.
Okay, but very often you use a flap, you bring the flap into the neck, which kind of flap, it doesn't matter, and you think you have a flap lying on the floor. There's no connection between the tissue under the flap and the flap. And we see it very often after more than 70 gray radiotherapy. Do you have the same experience? Perhaps your radiotherapist use less
I don't think,
less dosage?
If the dose of radiation therapy actually does not matter if you have vascularized tissue, because we would often go and put brachytherapy in addition to the previous 7,000, because there is residual disease along the carotid sheath. If you have vascularized tissue and if you have debrided marginal skin, that flap will eventually heal. I have not encountered that problem, that you brought in a vascularized flap that did not get stuck to the underlying bed with no pharyngeal contamination. If the pharynx is closed, there is no salivary leakage, I don't think there is a problem.
Okay. Dr. Olsen's same experience?
Yeah, my experience in these cases it's very similar to what Dr. Shah said. If you have no problem, if you have no communication with the mouth, the larynx, and you're doing an isolated neck dissection, sometimes you'll find that after the surgery, there will be a slow progressive loss of skin. I've seen that happen after neck dissections. And you can have major wound healing problems. Although it's not common, I've not seen a problem, however, with that not being able to be covered in most cases with just using a pectoralis muscle or pectoralis myocutaneous flap.
Dr. Lehmann, same?
Yeah, as I said before, anyhow, when the pharynx has been opened, as the previous speakers, we always bring in vascularized tissue. But in isolated neck dissections, even when the pharynx has not been opened, we would be more liberal as to use of preventive flaps nowadays, because we have really seen some problems as you are just showing us here.
Okay.
I think we should also look on the individual patient. We have drinkers and smokers, and their vessels are in different conditions, and if we make our decision having comorbidities and complication in mind, then it's easier to find the right way to avoid a case like that.
You just described our typical patient. But, yeah.
Okay. Any question from the audience?
Continue.
I just wanted to comment that it's one reason why we tend to favor the 6-week window of operating, because we rarely see this when we intervene earlier, but the later we wait to operate, the more problems we have. The other issue I would comment on is the extent of the neck dissection, and I think it'll be really important to see Dr. Shah's data this summer. Albeit it was a retrospective series that I mentioned in a small number of patients. I think what we saw, this recurrence at the primary site as well as the neck, says to me that this is a tumor that has either lost apoptotic mechanisms or something that has a different biology that's resistant to such rigorous therapy as radiation or chemoradiation, and that didn't respond at the primary or the neck, that the extent of surgery is probably not going to be the issue here. And I tend to push these patients towards our medical oncologists to give them some form of systemic therapy, which may, outside the clinical protocol, isn't probably the best thing to do, but currently we don't have such a protocol. We did in the past.
We have earlier done a fair amount of neck dissections after hyperfractionated radiotherapy. And when we do them between 3 and 5 weeks, we see much less problems with wound healing. We don't have too many yet of the chemoradiation cases, but the same seems to hold true there. So at least if we feel that we need to do a neck, we go in within that time frame.
Okay, but this question we mentioned before. the time after the end of the chemoradiotherapy. But my impression is the same. In my opinion, we should perform the neck dissection, if the neck dissection is planned, during the first 3 months after the end of the chemoradiotherapy. And it depends on the radiation dosage. And in my opinion, up to now, the right dosage is not found. Perhaps we could go a little bit back to 68 or 67 gray. Dr. Len, could you say anything about this?
You're completely right. For a very large tumor, there is no clear dose-response relationship. And in my opinion, one should stop at 70 or 72 gray. We don't go further, at least not with conventional technologies. It might probably change if we have more IMRT with some skin sparing and high doses in a smaller volume. But this is the future.
Okay, that's great.
My comment goes in the same direction. We cut it at 70 gray in tubing, and I've never seen such examples. So we just keep the dose in the neck at the highest for 70 gray if we combine it with chemo, and we never see such nasty things.
Okay. From Tübingen to Erlangen is not too far. You can come and we can show it.
You know, one of the things I think we can't overlook in these cases, though, too, is the whole issue of, as was mentioned, is comorbidity. It's so common in our patients, and if you have an individual like this who's nutritionally depleted, alcoholic, smoker, diabetic, on top of, I don't care if it's 68 or 69 or 7200 rad, I mean, you can have problems like this. And that, I think the comorbid conditions certainly have to be looked at.
Okay, we are a little bit late, but we started late, and therefore thank you very much for the panelists, thank you very much for the audience, and let's come to the next point. Thank you very much.
Sure.